खाना है, सब कुछ पता है, तो मैं भी अब्सॉर्ब करती हूँ। है ना? जैसा प्रॉम्प्ट
गुड आफ्टरनून आनंद।
जी गुड आफ्टरनून सर।
अमित सर आ गए क्या?
नहीं आया है सर,
संजय
दो
सर
मिनट
आ
में
गए?
ज्वाइन कर रहे बोले।
संजय सर भी नहीं
नहीं,
है?
संजय सर नहीं आया। नहीं नहीं।
डॉक्टर विजय?
अवनीश सर बोले हैं कि 2 मिनट में ज्वाइन कर रहे हैं।
कराओ कराओ।
हम्म,
हमको बता देना है ना।
सर।
हेलो गुड आफ्टरनून सर।
गुड आफ्टरनून सर, गुड आफ्टरनून।
गुड आफ्टरनून। जस्ट वो लैपटॉप से हम जुड़ जाते हैं सर।
हाँ
तो
हाँ जी।
Hello, hello.
यस, गुड आफ्टरनून अमित सर।
Welcome to the series of short certificate courses by ICP. Welcome, Dr. S. S. Daria, sir.
थैंक यू सर।
Are we late or can we start?
ना,
we
यस
can
वी
start,
शुड
sir.
स्टार्ट।
So, without wasting much time, let me introduce you to today's speaker, rather teacher of teachers, Dr. Avinash Singh, who is a clinical hematologist, DM in clinical hematology, and is a practicing hematologist at Paras HMRI Hospital, Patna. And today he's going to talk on the different hemoglobinopathies prevalent in India, which is an often less talked about but clinically very important topic. So let's welcome Dr. Avinash.
Yes. So,
Welcome.
वेलकम डॉक्टर अविनाश।
yes, sir. Yes, sir. Good afternoon, everyone. Thank you, sir. Thank you, Dr. Amit Das, sir, for nice introduction. I would just like to share my presentation, and I would like to thank the team for giving me opportunity to speak today. So, how to share? Share option is not there. Anand is there. How to share? Stop video more. Uh, can anyone help? So share option is not there.
सर मोर में होगा सर शेयर ऑप्शन।
मोर में सेटिंग्स है, कैप्शंस है, रिकॉर्ड है, ब्रेकआउट रूम्स है, स्टॉप इनकमिंग वीडियो, रिटर्न टू डिफॉल्ट्स है।
सर हम यहाँ से शेयर कर दें आपका पीपीटी?
ज़्यादा अच्छा रहता कि हम यहाँ से करते। तो स्टॉप सेटिंग्स में होगा क्या? नहीं,
रिएक्ट के बगल में सर एक ऑप्शन होगा शेयर का, ग्रीन कलर का बटन होगा।
ग्रीन कलर कोई नहीं है। रिएक्शंस के बगल में सिक्योरिटी है, चैट, रिएक्शन, सिक्योरिटी, एआई कंपेनियन। अच्छा ठीक है, आप कीजिए। आप कीजिए। अच्छा, ऊपर तो नहीं है कहीं ऑप्शन में? अच्छा, आप कर दीजिए, शेयर कर दीजिए। स्लाइड शो मोड कर दीजिए। हाँ, ठीक है, ठीक। थैंक यू, थैंक यू। तो जब हम बताएंगे तो आप बढ़ाते जाइएगा। सो अगेन गुड आफ्टरनून and thanks for opportunity. So today we will have presentation on common hemoglobinopathies in India. So for about half an hour we are going to discuss what are the common hemoglobinopathies. Sorry for the some this one spelling mistakes. So what are the common hemoglobinopathies which are common in, no, don't move. So which are common in our country, and briefly I would touch upon how to diagnose, how to prevent, how to manage the commonest one like thalassemia major, non-transfusion dependent thalassemia, and sickle cell disease. So why this topic is important? This topic is important because first of all anemia is very common. So around one fourth of population or one third of population in our country is anemic. And anemia is so common that in our practice we consider an anemic patient, suppose hemoglobin is 9, we are having habit of saying that no, it's normal for you, you are not having any disease or something like that. So we all will have to change our mindset. Until unless we respect anemia, we consider anemia as problem, we will not be able to detect cases of hemoglobinopathies. We will always, most of the time, we will miss them. Conditions like thalassemia minor, non-transfusion dependent thalassemia, or thalassemia intermedia, they will be missed. They may have hemoglobin of 9, but they may have iron overload. They may have massive splenomegaly. They may have cholelithiasis. They may have lots of complications of hemoglobinopathies if we don't detect them on time. And it's not only important for the patient who is sitting in front of you, but for their whole family. So it's very important. This topic is very important for all postgraduate students who have joined today. Next. Yes. So whatever we know about hemoglobinopathies is because of Dr. DJ Weatherall, who has done lots of work on thalassemia, along with Nancy Olivieri, and we lost him, DJ Weatherall. We lost him about 4 to 5 years back. He has done lots of work in the field of thalassemia or hemoglobinopathies. And in around 2010 or 11, he was in Kolkata for one Asian Thalassemia Group meeting where we had opportunity to listen to him. And the first one is Dr. E. Donald Thomas, who is considered as father of bone marrow transplant, who did first bone marrow transplant in 1975, for which he got Nobel Prize. Next slide. So some of the information I have taken from this some guidelines which was published in 2016 on prevention and control of hemoglobinopathies in India by NHM. Next slide. So the burden of hemoglobinopathies is huge in our country. Since we are populous country, so we have lots of cases of hemoglobinopathies because the carrier frequency is there. It's around 3 to 4% in our country. For beta thalassemia carrier population, prevalence is 3 to 4%. And there are some communities where the percent or prevalence is higher, as in Sindhis, Punjabis, Gujaratis, Bengalis, Mahars, Kolis, Saraswats, Lohanas, Gauls. So this is about beta thalassemia. About beta thalassemia, every year in our country, around 10,000 children are born every year. 10,000 transfusion dependent thalassemia who require blood transfusion every month since about 6 months of age for their whole life. 10,000 children are born in our country. It's a huge burden. You can't imagine how many thalassemia major children are there or adolescent childs are there in our country, and their condition is pitiable. Second group is of sickle cell disease. That is also very common. HBS or sickle is highly prevalent in the tribal populations of southern, central, and western states. In some of the communities, it's around 48% carrier frequency is there. Just like that, hemoglobin E is there, another hemoglobinopathy, which is common in northeastern states, and carrier frequency can go up to 50%. And the frequency is lower in other eastern states like West Bengal, Bihar, Uttar Pradesh. And HBD, it is also called HBD Punjab because they are mostly seen in Punjab, so the frequency is 2%. This minor frequency, carrier frequency is very important because you have suppose 3 to 4% out of 100 are having thalassemia minor. And when the population, when marriage happens, when two minors are married, their children can have thalassemia major. Like sickle cell trait, marrying sickle cell trait, they can have sickle cell disease. So the frequency of carrier frequency is very important. There is one country, Cyprus, where the carrier frequency is around 27%. And you all know the court, they have given guidelines or the order that before marriage you have to produce the carrier status. Two minor can't marry in Cyprus, and that's why they have controlled thalassemia in their country. So we need rules like that to prevent birth of a thalassemia major, sickle cell disease, or E beta thalassemia. It's very important. The rules may not change in one day. We can't change the mindset of politicians. But as a doctor, as a trainee student, it's our whole sole responsibility. And if we understand this fact, we can prevent birth of a thalassemia major or sickle cell disease child. So this webinar is successful if we all are committed, and there should not be birth of next child of thalassemia major or sickle cell disease after this webinar. In our practice, we have to be very careful. We have to look for how we can prevent, how we can catch minors. They are very difficult to catch because they are as normal as we are. So it's very important to understand these things I have said. So next slide. And this is all about hemoglobin molecules. So they have alpha and beta chain and also heme units with iron atom. So this is how hemoglobin is formed, and we are going to discuss the problem of hemoglobin molecule. Next slide. Yes, so beta thalassemia syndromes. So they can be thalassemia major or thalassemia intermedia, and these type of phenotypes or genotypes can be there. It could be uh, trait, it could be both homozygous beta thalassemia, it could be combination of compound heterozygous. So depending upon the different subunit they have, like thalassemia minor with hemoglobin depot or something like that, combinations it can be. Next slide. Yes, so what happens in beta thalassemia? In beta thalassemia, the beta chain is affected, so there is impaired beta globin chain synthesis. So what happens when beta chain is deficient? Alpha chain is having excess, relative excess. That leads to abnormal erythroblast formation. The membrane is damaged, So they most die in marrow, leading to ineffective erythropoiesis that leads to anemia. It will lead to tissue hypoxia, increased erythropoietin. So more and more extramedullary hematopoiesis takes place. There will be expansion of bone marrow, and that's why the skull of thalassemia or the maxilla of thalassemia major child is broader. So there will be a skeletal deformity, hepatosplenomegaly, increased erythroferon. There will be suppression of hepcidin, increased intestinal iron absorption, systemic iron overload, and also because of regular blood transfusion, there is iron overload. So there is secondary hemochromatosis, which will damage the cardiac tissue, the liver tissue, and there will be death. As well as the abnormal erythroblast will lead to few abnormal cells intercirculation, precipitation of alpha globin aggregates with membrane damage, and again there will be extravascular hemolysis in the spleen. So this is what happens in thalassemia major or intermedia, and that's why patient suffers. Next slide. Another entity that we are going to discuss is sickle cell disease syndrome. So again, there can be homozygous sickle, like sickle trait. Both genes are affected. So sickle cell disease, or it could be minor, or it could be some combinations, compound heterozygous like sickle beta thalassemia, sickle HBD. Next slide. So this is what happens in sickle cell disease. So there is beta globin gene. There is abnormal polymerization of the uh, molecule, hemoglobin molecule, which leads to uh, uh, destruction of RBC, and the precipitant factors are there like dehydration, fever, hypoxia, acidosis, infection. They can lead to more and more sickle crisis and all the problems of sickle cell disease. And the two features are very important. One is hemolysis that will lead to anemia. Then then there will be other complications of hemolysis like by damaging the endothelium, and there will be vasoocclusion. So all sorts of crises like chest crisis, pain crisis, strokes, renal involvement can be there in sickle cell disease. Next slide. Yes, so this is the typical phases of a thalassemia major child. You can see that because of extreme extravascular or extramedullary bone marrow is at stress. Hello, am I audible? Hello, hello.
Yes, sir, you are audible, sir.
Sorry, I got disconnected. So this is the typical phases of thalassemia major child. Next slide. Yes, this slide is very important. So thalassemia, if you read in books, there are many types of thalassemia, thousands of types of thalassemia. But as a clinician, what is important? So all thalassemia can be divided into two types. One is called non-transfusion dependent thalassemia, and another is called transfusion dependent thalassemia. So presently, we don't write in our prescription beta thalassemia major, we write TDT. That is, this child is dependent on blood transfusion. Or this child is not dependent, then we write NTDT, non-transfusion dependent thalassemia. So what will happen? Transfusion is seldom required or occasional required or intermittent transfusion required whenever there is need in NTDT. Suppose there is pregnancy, NTDT, a lady has got pregnancy, so they will require transfusion for some time. After delivery, they may not require transfusion. Or if there is infection, then they may need transfusion for some time, and after that transfusion is stopped. But TDT patients, transfusion dependent thalassemia, they are dependent on transfusion for their survival. So we have to all patients who come to us of thalassemia, we have to differentiate whether it is TDT or anti-TDT. Next comes the diagnostic workup. So thalassemia patients, anemia is the hallmark. TDT patients or anti-TDT patients, anemia is the main symptoms, and there will be other symptoms, involvement due to iron overload and problem due to iron overload. Now coming to how to diagnose. So full medical history, family history is important. And the first investigation, I always say that first investigation that you should write is not hemoglobin value. It will not give you information which you need. You should order a complete blood count. That is very important. And it's available everywhere in all medical colleges, in all districts. So CBC is important, and in CBC we should look at hemoglobin, RBC count, MCV, MCH, WBC, platelet, differential, everything we should see. We can order peripheral smear reticulocyte count. If suppose MCV, MCH is low, MCV less than 80 and MCH less than 27, then we should look for on peripheral smear. This is microcytic hypochromic target cells inclusion body we should see. Next test we should order is ferritin. This is very important. Serum ferritin is very important. So serum ferritin, if it is less than 12, it is iron deficiency. And there are many study or guidelines which say that less than 30 is considered iron deficiency. I, in my practice, consider 30 as the cutoff. Less than 30, I treat with iron. More than 30, I think that it's not iron unless some acute inflammation is there. As per this algorithm, if ferritin is more than 12, then do HbHPLC. In this setup, where there is anemia, microcytic hypochromic, and ferritin is more than 12, do HB electrophoresis. And depending upon the values of HbA2 and F, it's very important. HbA2, if it is more than or equal to 4%, it is minor thalassemia or trait. If it is more than 4%, but HbF is also high, 5 to 10%, it could be thalassemia intermedia or major. If it is HbA2 is more than equal to 4%, but HbF is less than 1%, there can be other possibilities. Again, if HbF is less than 5 to 25%, HbA2 is more than 4%, then possibility of HbH disease is there. Other HB variants are possibilities. So these are screening tests. So they will suggest that there could be thalassemia, whether it is minor or major or other combinations, compound heterozygotes. The final confirmation should be done by mutation testing, which mutation, characteristic mutation patient has or not, like DNA analysis for alpha and beta globin mutations. So we have some molecular panels, we have NGS to detect these disease. Next slide. So this is all what I have said, that we should do CBC, peripheral smear, and HbHPLC. Depending upon their finding, we can we can do that. So for suppose for sickle cell syndrome, what will happen? HbS will be high. HbS will come more than 50% in sickle cell syndromes. Next slide. And this is all about, depending upon the HbA2, HbF, MCB, MCH, you can differentiate different genotypes like beta thalassemia trait, Lepo trait, delta beta thalassemia trait, and other combinations. We can have some idea. Next slide. Yes, so we all know that suppose a carrier for thalassemia is marrying a girl who is having normal gene, normal globin gene. Then there will be possibility that two of the child are carrier. 50% of children can have carrier status, and the 50% can have normal. Okay. Next slide. And how to prevent thalassemia? This is very important. So there are many tests which are available and which cannot be done, which are there for population screening. Like suppose there is camp, so you will not have this one HbHPLC machine or hemoglobin electrophoresis machine to keep their use in camps. But so there are some tests like Nestrov test, DCIP test, solubility test. They are easily or rapidly available tests, so they can guide us in community level where large number of populations are there to screen for thalassemia and sickle cell trait. So these are important. They are not for institutional use, but for community purposes. For screening of these hemoglobinopathies, they are used. Next slide. They have their own limitations. I will not go into detail. Next slide. Yes. So this is just that initial screening. These are the tests we should do, and then diagnostic first test we should do HbHPLC. And as I have said, confirmatory is always done by DNA based test. Next slide. And these are the different genotype, and depending upon the pattern on HbHPLC, we can have different idea that okay, these are there on HPLC, so this is a possibility. So we can have some correlation that these things we are getting on HPLC, so genotype can be like this. Next slide. Yes, so this is all about the screening. So when you do this is about pregnancy. So what happens? Suppose both the partners are having thalassemia minor and the mother is pregnant. So how we can prevent thalassemia major in our society? So first is marriage between two minors should not be done, should be avoided. First thing, and many countries they have adopted this strategy and they have controlled thalassemia. But in our country, due to social reasons, it's not possible that you will have law or you can a girl's father will not disclose this fact that my daughter is having thalassemia minor, because marriage can be a problem. So if suppose after marriage we know that both partners are having thalassemia minor, then during pregnancy, during initial trimesters, first trimester, around 3 to 4 months of pregnancy, we can do some test to look for whether the fetus who is there is having thalassemia major, minor, or they are normal. So this chart just show that these are the ways we can do some investigation to look for whether that fetus is affected or they are normal. Next slide. And in Eastern India, this is one from one paper that these were the mutations of beta gene mutations were found. So most common was IVS 125G2C, and others were less common for regarding beta gene mutations. Next slide. And regarding alpha gene mutations, so mainly deletional problems were there in alpha gene. So these were there in alpha. You can see these were there. Single deletion, double deletion, replications were there. Next slide. And on the Indian map, you can see that this is the carrier frequency of different diseases like beta thalassemia, HBS, and E. So you can see the sickle cell belt is this one, Odisha, Chhattisgarh. These were sickle cell belt, and thalassemia belt is shown in green. So, and the E is in mostly in northeastern parts of our country. Next slide. Now coming to the management. Next slide. So the management outline of thalassemia major. So first is replacement of hemoglobin. So hemoglobin is deficient, patient is symptomatic. So we have to do blood transfusion with packed red blood cells. And since because of reasons I have shown, there will be iron overload. So we need iron chelation for iron overload, as well as there will be complications due to thalassemia major as well as iron overload. So monitoring of complications due to disease and their treatment, management of complications like endocrine, cardiac, skeletal, and bone marrow transplant or hematopoietic stem cell transplant is the only curative treatment for transfusion dependent thalassemia. And this is a disease of children. They grow, they go through adolescence and adult age. The family is suffering, parents are suffering, so they need psychological support too. Next slide. as per this stiff guideline, Thalassemia International Federation guidelines, so after confirmatory diagnosis of thalassemia and when we should start transfusion. So hemoglobin level less than 7 on 2 occasion or more than 2 weeks apart, including all contributory causes. And if there is, even if hemoglobin is more than 7, but there are some features like facial changes, poor growth, fracture, clinically significant extramedullary hematopoiesis, that is large spleen, then we have to start transfusion. Next slide. And always pre-transfusion target we should keep 9 to 10.5 gram per deciliter. That is before transfusion, child's hemoglobin should be 9, at least 9. But practically it's not possible. There is lack of blood donors. Blood is not available in blood bank. So practically we keep just more than 7. But when the family is motivated, they are planning for a stem cell transplant, they have donors, we try to keep at more than 9. Which type of blood? As I have said, PRBC, and that should not be, that is, PRBC can be stored in blood bank for about 42 days, but we should try to use not more than 2 weeks old PRBC. And there should be a screening for HIV, hepatitis B, C, malaria, syphilis, and it should be NAT tested. How much blood to be transfused? It should be 15 ml per kg body weight, and monthly transfusion is required to keep hemoglobin more than 1, and sometimes there may be RBC elimination. So this 15 ml per kg per month blood is not sufficient, so we may have to increase to 20 ml per kg per body weight, or we may have to decrease the frequency to every 2 weeks or every 3 weeks to keep hemoglobin more than 9. Next slide. Yes, now once you have corrected the anemia part, blood transfusion has been done. So there is another complication of transfusion dependent thalassemia, or NTDT, is iron overload. So we do test by serum, we measure serum ferritin, and there are some tests like MRI of liver and heart can be done to look for their iron related problem. Liver biopsy can be done, but it's invasive, so it's not so favored. And when to start iron chelation? So when the serum ferritin, when the transfusion has been done for 10 to 15 times and the serum ferritin is value is more than 1000 microgram per liter, we should start iron chelation. Next slide. So this is what happens in transfusion dependent thalassemia. The non-transfusion bound iron, it enters inside the cell. They are labile iron. They will have metabolic use, reactive oxygen species, and ferritin storage loop. They are stored. They can lead to lipid peroxidation and organelle damage. There will be cell death. So this is why we need to correct the iron overload, which is there. Next slide. Yes, so regarding iron chelators, we have two oral iron chelators, another injection. Like desferrioxamine is injection, which is the oldest iron chelators we have. So, but the problem is of availability, and we need one pump to use it, which is not readily available. But there are some centers, thalassemia daycare centers, they have available this drug, and battery-driven pump, which is easy to use. This is the best iron chelator that we have, and this is the dose we should start. And these two, like deferriprone and deferasidox, are oral iron chelators. So we usually start with deferasidox, and if there is problem in there is no good iron chelation, then we add deferriprone, and sometimes we have to combine the desferrioxamine too. Next slide. And this is all about how to monitor. Once we have started iron chelation, then how to monitor. So serum ferritin we can do. Different countries, they have different guidelines. So every 3 months we monitor. And liver iron concentration, the cardiac T2 star, wherever they are available, that should be done every 6 months or like that. Next slide. So this is all about serum ferritin and liver iron concentration. So we always try to keep less than 1000 nanogram per ml. Next slide. Next slide. And this is another from Australian practice guidelines. They also say that we should start with this much dose, deferasidox 20 to 30 mg per kg per day, and we monitor for iron overload. If they are in control, then it's okay. Otherwise, we will have to add another iron chelator along with that. Next slide. Now coming to the curative treatment, so bone marrow transplant or hematopoietic stem cell transplant is the curative one, and all the guidelines throughout the world, they say that matched sibling donor is the best. This one stem cell donor for hematopoietic stem cell transplant for thalassemia. It's curative, and depending upon the iron overload and other complications, so there are some uh, three grades are there: class 1, class 2, class 3. So class 1 are the best patient to go for transplant. They have more than 90% or 95% overall survival, and class 3 are the bad patients where there is more iron overload, liver fibrosis is there, so their result is around 70 to 80%. And as early as we do bone marrow transplant, like 3 to 4 year of age, it is the best is to get the most success in stem cell transplant. Next slide. So if there is matched sibling donor, that is the accepted uh, HSCT strategy. If suppose siblings are not there or sibling is not HLA matched, then we can do matched unrelated donor transplant, which is also accepted strategy. Other alternative modes like haploidentical transplant, they are still considered as experimental for thalassemia major. Next slide. But there are some centers in India which are doing good haploidentical transplant with good success. So if a family is motivated and they understand the risk of transplant, because the haplotransplant is toxic, they have complications, more complications compared with mud or matched sibling donor, so they can go for that. Next slide. Next slide. Yes. So other than blood transfusion, iron chelation, and hematopoietic stem cell transplant, there are some drugs which are there we commonly use in patients who can't go for transplant, who and there are some drugs like hydroxyurea has been tried in non-transfusion dependent thalassemia, and we have found that one third of patients can have some transfusion independence or reduction in transfusion frequency. Thalidomide, there are many centers in India, and also we have used in some patients, and we have found that around 30 to 40% of patients, mostly of anti-DD type or patients who have required less transfusion, they got benefit. Even thalassemia major, some of the patients they had improvement. Luspatercept is another agent which has been approved for transfusion dependent thalassemia who are more than 16 to 18 year, and they have also found that one third of patients can have transfusion independence. Next slide. This is all about these drugs that I have said. Next slide. And regarding gene therapy, so gene therapy also has been approved for thalassemia major recently, and but it's not easily available in our country, and its cost is prohibitive. But there are some phase 3 trials has shown that around 80 to 90% of patients had transfusion independence. Next slide. Regarding coming to sickle cell disease, so sickle cell disease is characterized by sickling. So all of your medicine residents or pediatric residents, you should see the peripheral smear of a sickle cell disease. You will see the sickle sepid RBC, and these are the genotypes. We can see sickle homozygous, sickle combination of compound heterozygotes. Next slide. And these are the problems that we see, like painful crisis, chest crisis, acute complications, painful crisis, chest crisis, splenic sequestration crisis, aplastic crisis, cerebrovascular event, priapism, dactylitis, acute thrombotic event, and chronic complications because of tissue hypoxia and endothelial damage. There will be pulmonary hypertension, heart failure, renal failure, liver failure, cerebrovascular accident, avians, osteomyelitis, legal. So it's a multi-system disease. All each organ can be affected. So we have to be very careful. It's a multidisciplinary approach. So it's not a hematologist or pediatric hematologist job. We have to coordinate with cardiologist, neurologist, nephrologist to look for all complications. Next slide. So, what is the management strategy in sickle cell? So, penicillin prophylaxis prevents pneumococcal sepsis in children, and pneumococcal vaccine prevents pneumococcal infection. Then, transfusion to reduce HbS level below 30% to prevent strokes in children with high CNS blood flow. And hydroxyurea is very important. So, that decreases crisis in patients with severe sickle cell disease. So hydroxyurea we use along with folic acid in all sickle cell patients. Next slide. And there are some new drugs which are there for sickle cell, like tijanlizumab is there, which is a P-selectin targeted monoclonal antibody, and they have been approved for prevention of veno-occlusive crisis in individuals aged over 16 years with sickle cell disease. Another drug is voxelotor, is an oral HbS polymerase inhibitor which reduces hemolysis. L-glutamine that we use reduces hospital admission, chest crisis, and veno-occlusive events. And hematopoietic stem cell transplant for sickle cell disease is curative in around 20% of individuals who have matched donor, and but it has risks. So these are all about sickle cell. Next slide. So to conclude, this is the last slide. So we should all have to prevent disease. Very important. Prevent thalassemia major, that transfusion dependent thalassemia, sickle cell disease. Transfusion is important for transfusion dependent thalassemia and for some sickle cell patients, and prevent complications. Use disease modifying agents where it's eligible. Novel agents are there, iron chelators are very important. HSCT is curative for transfusion dependent thalassemia and some of the patients of sickle cell disease. Gene therapy has hope for TDT patients. So thank you all. If there is question, we can discuss. Thank you. So questions are there in chat box. So
Thank you so much, Avinash sir. It was really great derivation. You have touched upon everything regarding the hemoglobinopathies in India. So now this is time for the question answers. Uh, First
thank you.
question is, sir, treatment of sickle cell crisis, role of bicarbonate.
Yes. So sickle cell crisis patients, two things are very important. One is adequate hydration, vigorous hydration. So fluid should be given enough. It's very important because dehydration is one factor which will lead to sickle crisis as well as all complications of sickle. So it's very important. So many times we give 3 liter per meter square of IV fluid. The role of bicarbonate is not so clear. So whenever needed, if suppose there is some renal complications, I would consult our nephrology colleagues. Depending upon the ABG findings and others, we may have to add bicarbonate, but it should not be general strategy to add bicarbonate in all patients, sodium bicarbonate in all patients, along with IV fluid. Yes, sir.
Yes, definitely, sir, because bicarbonate is only needed once the ABG is showing there is some
Yes.
in bicarbonate, low bicarbonate.
Yes, sir.
Otherwise, generalized, we never use the bicarbonate. We can use the IV fluids in that condition.
Yes, sir.
Next question is gallstone prophylaxis in hemolytic anemia.
Uh, See, gallstone prophylaxis, hemolytic anemia. So, we should try to prevent hemolysis or to reduce hemolysis. Okay. So, that we can do by managing the primary disease, whatever it is. It is transfusion dependent thalassemia or NTDT. So, if we reduce the hemolysis by either suppose blood transfusion or by disease modifying drugs like hydroxyurea or others, as I have said, or you do transplant, that is the only preventive ways to prevent gallstone. Okay.
Yes, sir. The next question is sickle cell anemia leading to CVA hemiparesis. How to treat, sir?
Yes, so CNS stroke in sickle cell anemia is also one of the complications of sickle cell disease, and there again comes that we have to try to reduce the sickle population, that is less than 30% we should try to keep. So the strategy is either we can give hydroxyurea, that we do, and we have to try to give blood transfusion so that there will be the HbS population is less than 30%, and we have to monitor the transcranial Doppler velocity, that is important, along with help of neurophysician we have to manage that. And if suppose neurophysician they suggest, we may have to use antiplatelet agent or anticoagulation along with that. So that is all about CVA.
Any analgesic used in sickle cell crisis, sir?
Yes, yes. So sickle cell crisis, pain crisis, when it is there, we have to use analgesics. So that is the main component of sickle cell crisis management.
So any particular choice or any analgesic we can use, starting from COX-2 inhibitors to NSAIDs and
So most of them they respond to NSAID like ibuprofen or something like that. We can give, suppose child is weight is more, we can give IV paracetamol, tramadol we can use. So these are the options, and many times they don't respond to these agents, so we may have to use morphine or something like that. So we have to patient-centered individual approach we have to follow. But NSAID is usually that is the first drug that we start with.
thank you so much, sir. I think there is no other questions left in the chat board. So, Dr. Amit Das, sir. So, another question is there maximum dose of hydroxyurea that
Yes,
can be given in a day and how to monitor for adequate doses and side effect of hydroxyurea.
yes. So hydroxyurea usually we start with 10 mg per kg per day, and after starting hydroxyurea, after 2 to 3 weeks, we see the CBC, and we try to keep the WBC count more than 3000. And maximum we can then gradually, if suppose there is no response or the frequency, the crisis frequency is not less, not reduced, then we can increase to 20 mg per kg. But what I remember, maximum 30 to 35 mg per kg per day we can give hydroxyurea depending upon the tolerance. The one is TLC, another is other side effects of hydroxyurea like leg ulcer, oral ulcer that we have to look for. And that is all common side effects of hydroxyurea is oral ulcers, leg ulcer, non-healing ulcer, and leukopenia. Leukopenia, sometimes even pancytopenia can happen. So we have to start with low dose and gradually we should titrate.
Someone is asking, sir,
Yes, sir.
that how to know when to increase dose of hydroxyurea.
Yes. So it will depend upon for what purpose we have started. Suppose for non-transfusion dependent thalassemia, we have started hydroxyurea. So we have started the dose, and we will wait for about 2 months, 1.5 months to 2 months, and we will see the transfusion frequency. If the transfusion frequency is gradually reduced, then we will continue the same dose. Suppose in 3 months' time there is no change in transfusion frequency, and patient is tolerating the hydroxyurea, then we will increase the dose. But in clinical practice, it is difficult to wait for 3 months. Even for 1.5 to 2 months after that, we increase the dose too. If patient is tolerating, then we will increase the dose of hydroxyurea.
Thank you so much, sir.
Thank you.
Anybody want to ask any more questions? The starting dose of hydroxyurea, any loading dose of hydroxyurea?
Uh, we usually start with 10 mg per kg per day. So there is no bolus dose or something like that. We start with 10 mg per kg per day.
Thank you so much, sir. Is there Dr. Amit Das is there? Anand?
Yes, sir. Sorry, here, sir.
Anybody from the headquarter ICP? So anyway, on the behalf of our post director, Dr. Sudhir Mehta, sir, and Dean ICP, Dr. Kamlesh Tiwari, sir, thank you so much, Dr. Avinash Singh, sir, for nice deliberation and clear everything about the hemoglobinopathies in India. I hope that all residents already have taken the knowledge about these hemoglobinopathy. Thank you so much, and thank you everybody who have joined, and all the residents also. Thank you so much.
Thank
Thank
you,
you,
sir.
sir.
Thank you.
Yeah.
Thank you, and thank you, everyone. Thank you. Thank you, sir.